Let's talk about varicose veins. Before getting into the topic, let's have an overview what all we are going to study inside it. We'll study the basic anatomy of the venous system. Then we will understand what is the pathology or defect into it which is resulting into varicose vein. Then we will see that due to those effects, how patient is going to present to us, like what will be his complaints and what will be the clinical features you will see in him. And once a patient is in front of you with such clinical features, you will do the clinical examination. We will study about what all clinical examination tests we need to do. Then we'll go for the investigation. Then we'll plan the surgery, and we also do the grading along with it. And later we will study the complications, like if a varicose vein is not treated or the complication of the surgeries. So let's start. Starting with the anatomy of the venous system, it is divided into two parts, the superficial system and the deep venous system. Around 80% of the blood flows in the deep venous system and 20% flows in the superficial venous system. In the deep venous system, we have three pairs of deep veins, which are the peroneal veins, anterior tibial, posterior tibial. Whereas in the superficial system, we have the great saphenous vein and the short saphenous vein. And you must be knowing the paths of the great saphenous and the superficial great saphenous and the short saphenous vein. The great saphenous starts from the medial end of the dorsal venous arch and goes till the saphenofemoral junction, and whereas the short saphenous vein arises from the lateral end of the dorsal venous arch and it drains at the saphenopopliteal junction. So this is the difference. And during the surgery, if we are touching the great saphenous vein, it can result in the injury of the saphenous vein, and whereas if we are interfering with the short saphenous vein, it can result in the injury of sural nerve. So this was all about the basic anatomy. Then coming to the topic itself, like there are perforators which connect the superficial veins to the deep veins, and when the perforators get incompetent, there is reversal of flow that results in the varicose vein. Usually, the normal path of the blood is from the superficial vein to the deep veins. Just imagine yourself exercising, doing some calf muscle exercises. The calf muscles compresses the deep vein, which actually forces the blood to flow from the superficial venous system to the deep venous system to the perforators. But in the patient who is having this varicose vein, this will be incompetent. The blood will also flow in the reverse direction, which is resulting in the dilatation of the superficial veins. So this is the first complaint with which the patient comes to you, right? Dilatation of the superficial veins in the lower leg, and also later these swelling can develop into some skin manifestations like corona, phlebitis, atrophy blanchi, lipoderma sclerosis, ulceration. Corona phlebitis is the malleolar flare which is seen around the medial malleolus. Atrophy blanchi is a pale white area surrounded by dermal flares. Ulcerations can also be seen. So this was all about the clinical features. Then coming to the investigation and clinical examination. In clinical examination, we will do the tendon work test, we do the modified Perthes test, we do the short cuff and pulse test. You can see the details videos of it. In tendon work test, we tie a tourniquet around the saphenofemoral junction, then remove the tourniquet. If it's rapidly filling, then it indicates the incompetence of the saphenofemoral junction. If it's filling from below, then it indicates the perforators are damaged. Whereas the modified Perthes test is used to rule out the deep venous thrombosis. And the next is the short test. A thrill is felt when we tap over the vein. And the Morrissey's cough impulse test is a thrill is felt when the patient is asked to cough due to the incompetent saphenofemoral junction. And the investigation of choice is the Doppler with B mode ultrasound. Coming to the specific management, we have the adjunctive management and then definitive management. In adjunctive management, we use the compressive stockings and dressing for the ulcers. In definitive management, surgery is the treatment of choice. We do the traditional surgeries and the newer techniques. The traditional surgery is the tendon work surgery, where we do the flush ligation at the saphenofemoral junction. And in the new surgeries, we have the endovenous laser therapy and the radiofrequency ablation. So these are the surgeries. Now coming to complications. Complications, as discussed earlier, there can be wound bleeding, skin manifestations, wound infections, ulcerations. So this was all about varicose vein. Thank you for watching.